Andrew Mason, who some of you may know, but I suspect others don't. Andrew was a new volunteer to our committee just this year in March when we had our AGM, and he's helping us with several things on that. But he's here today to talk about his real job, and I'd like you to welcome him in your usual way. Thank you very much, Andrew.
Thank you. Before I start, I'd like to thank Lawrence for all the work he puts in getting the audiovisual stuff up and making me look as if I work in a call center. I'll try and sell you some insurance later. Pathology, the hidden science. Why have I called it the hidden science? I'd like to ask a question. Apart from having blood taken, how many of you have ever been in a pathology lab? 4. That's why we call it the hidden science. It's also hidden from a lot of other workers in hospitals because we're generally behind closed doors, locked doors for infection control purposes, confidentiality, all the rest of it. So I'm going to give you a bit of an overview of what we do there today. So pathology, it's not just about dead bodies, which is the usual comment you get when you mention pathology. It's, oh, it must be horrible working with those dead bodies. I've never worked with a dead body in 41 years. But I will be talking about blood. So if you're okay with that, we'll crack on. Oh, there's a biomedical scientist hard at work. You might recognize him. I got to admit, I wasn't actually working then. That photograph was taken for a newspaper article. So I was just posing. Yeah, so, but you may not have heard of biomedical scientists. I would imagine some of you obviously will have, but it's within pathology, it's the biggest staff group. There's around about 25,000 biomedical scientists in the UK, and they work in all different disciplines and are responsible, the tests we do in laboratories are responsible for between 70 and 80% of all diagnoses and ongoing care. So it's obviously a really critical part of the laboratory. What I'm actually doing there, I'm looking at these things, blood films. It's a slide made, just spread the blood thinly and then we stain it and we can look at it down the microscope because although we're automated now to count lots and lots of cells, the human eye is still better than analyzers at noting the fine details and changes. So there's still a place for human beings there. Although there are now computerized microscopes that can learn, so how long that'll last is another matter. Right, a little bit about me. Some of you might recognize that place. That's where pathology used to be. At the time of this photo, that was actually the orthopedic and fracture clinic, I think. And eventually we moved down there in this area. This was microbiology and histology. That was biochemistry. That was hematology and blood transfusion. And that was the mortuary. So it's interesting how they have mortuaries right next to intensive care. I got to say, it wasn't the best place to have a mortuary. Some days it wasn't very pleasant walking into work. 1985, we moved up to the Princess of Wales. And for about the first 2 months we worked there, there were no patients. It's probably the most idyllic 2 months I've ever had working in a laboratory. It was lovely. The hospital was great. And it was a fantastic environment to work in. We had brand new laboratories, new computers, everything. In 1990, I moved up to Surrey and went to work at the Royal Surrey County Hospital in Guildford. And that's where I worked for the next 29 years. Eventually ending up as the chief biomedical scientist in a department called Blood Sciences, which I'll tell you a little bit about in a second. But it's the Royal Surrey is one of the main cancer centres in the whole of the southeast. It's a very big sort of setup there, and they're just building a new unit. So it was an interesting place to work. Right, TV pathologists. I get a little bit frustrated watching television programs. These people seem to be better than the police at solving crimes. I don't know how they do it. They do all the work in the laboratory. There's no BMSs. There's no staff in the labs. There's just these guys. That's a real pathologist. That's my very dear friend, Dr. Jerry Robbins. He's a retired consultant hematologist, a cycling friend of mine, and probably one of the best doctors I ever worked with. And I think it's only fair that I show him looking a bit more serious. He's quite a character. Okay, this is a little sort of schematic of the pathology department I used to work in Guildford. As you can see, there are 4 main departments there. You've got hematology, biochemistry, microbiology, and histopathology. Mortuaries down there, so we can ignore that today. Histology and cytology. Histology is where they look at all the biopsies and all the rest of it that you have done. Cytology is where cytoscreening goes for cervical screening, that sort of thing. Microbiology, I never liked microbiology. It smelled too badly for me. But virology and immunology, I think it's really important to have a look at those guys because they did a huge amount of work during the COVID pandemic and I don't think they got the credit they deserved in NHS laboratories. New laboratories were set up really quickly all over the country. And sadly, there was a lot of bad press, but they were mostly in private labs. But that's just a bit of a bone of contention for me. Biochemistry and hematology are the department that I managed, which was called blood sciences. Biochemistry and peptides, that's looking at things like insulin and growth hormones, that sort of thing. Trace elements, used to be called trace metals. They measure things like chrome and cobalt. And we did a huge amount of work a few years ago when there was the worry about hip replacements, chrome cobalt hip replacements, because there was metal sloughing off the joint and getting into the system, and it was thought they might be toxic. So we were doing a lot of work on that. Peptides, I said we don't solve crimes. They actually did a lot of work. It came on the news last night, the Beverly Allett case. I don't know if you remember it. Peptides did a lot of work on that because people still seem to think they can kill people by giving them insulin. Well, this lot can tell whether it's natural insulin or man-made insulin and can also work out what batch it is as well. So they do a lot of work. And Dr. Gwen Walker, who ran that department in Guildford, was an expert witness at a lot of court cases where this had happened. Hematology, coagulation, blood bank, that's what I actually trained in. I trained as a hematologist. And that's what we're going to talk about today. Because to try and do all of that in one talk, for one thing, I'm not an expert in that. And secondly, it's much too broad a subject to deal with in one session. Let me catch up with my bits of paper. Okay. So hematology, what is hematology? It's the study of blood formation and the diseases which occur when the process goes wrong. This not only involves the production of blood cells, but also the proteins involved in blood coagulation. We'll come on to coagulation later. A little bit of history. William Harvey discovered the circulation of blood in 1628. So it's been around for a while. This guy, Jan Swammerdam, described red cells in the blood. William Houston described the different blood cells, and Max Wintrobe characterized the values. So how many red cells you should have, how many white cells you should have. Now that's most people's idea of a laboratory. That's actually a picture from Doctor Who. That's John Pertwee there as Doctor Who. But I couldn't find another picture of it. But this is what the lab looked like when I started. As you can see, so long ago, it was in black and white. That's an analyzer at the time. And at the time, we probably did about 100, 150, 200 samples a day in Bridgend. This is what the analyzers look like now. And Frimley Park Hospital, which is part of the group I worked in, is a main hub. They do between 8,000 and 9,000 samples a day. So it's a huge amount of work. You see, we're terribly intellectual in the labs. We name our instruments after Greek gods. So what happens with that is the sheer volume of samples, you can't possibly deal with it manually anymore. So these analyzers now, you load them up, all the samples are barcoded, they do the processing for you. They can count tens of thousands of samples in 30, 40 seconds. Once it gets to the end, that's transmitted to the laboratory computer. If there's anything out of the ordinary, the biomedical scientist will look at it, decide whether it needs any further tests done, and authorize it. Or if it's all within the reference ranges, it'll be automatically authorized. And within 15, 20 minutes, it'll be sent back to your GP. So if you get told it takes 2 weeks to get your full blood count result back, have a word with them. But you know, it's these analyzers cost about £250,000. And in the Guildford lab, which was an average size lab, we had 2 of those in hematology and 2 separate ones in chemistry. In Frimley, which is the big hub lab, there are 5 of those. So this is where a lot of the money in the NHS goes. Okay, that's a set of blood results. I can show you those because they're mine. And they're absolutely disgustingly normal and healthy. But you can see when they say we're going to do a blood test on you, that's the sort of range of stuff you get done. And that's a basic, straightforward U&E, LFT, and full blood count. So nothing special there. All that can be done within an hour of getting the sample in the laboratory. Some of the more specialized tests can take several days or even a couple of weeks. Okay, let's have a look at some blood. That's normal blood. Grateful for the fact that they labeled it all for me. Apart from that cell there, which is cut off at the bottom, that's called a basophil. Now, what do? Neutrophils, they're involved with fighting infections, like bacterial infections. Lymphocytes are involved in fighting viruses. They produce antibodies against virus. So when you get your vaccine, your flu vaccine in a little while, it's those that are stimulated to produce the antibodies against the vaccine. Eosinophils and basophils, they're involved in the allergic response. So if you've got an allergy, you'll have raised numbers of those. And you can see we can identify them by the fact that they stain different colors. And we use a stain, you can see those slides with purple earlier. We stain is called May-Grunwald-Giemsa is the stain. So remember that for later. And it's what's called a Romanowski stain. And there's different parts of it, acid and base, and the cells take up different parts of that. So you get different colors. So the eosinophil takes up the acid part. That's why it's bright orange. Basophils take up both. And neutrophils don't take up all of it, so they look like that. Platelets, tiny little cells involved in the coagulation process, and red cells, lots of red cells. So let's have a look at what blood's made up of. So there's a real sample. So 55% of your blood is plasma, 45% red cells. You can see we're not very good mathematicians in hematology because that adds up to 101%. I just noticed. So within those ranges. So that layer there is where the white cells are and the platelets. And I've wondered for a long time why it was called the Buffy coat. And I found out today, I looked it up today, and it's actually because they buff colored. So it's nothing scientific, it's just. And white cells because when someone looked at them first without staining, they were just white. There was no color to them, unlike red cells, which do have a little color. So that's a sample there, so you can see the actual layers in the blood that's spun down. So let's talk a little bit about red cells, first of all. They're the most common cells in the body. A teaspoon of human blood's got about 25 billion red cells in it. And you've got about 4.5 to 5 liters of blood in your body. So I'll leave you to work out the total number there. And there's 2 to 3 million red cells produced every minute. Second, sorry. Now, this is interesting. They have a volume about 80 to 100 called a femtoliter. Now, a femtoliter is zero with, I think there should be 14 zeros, 0.1 of a liter. Someone says a quadzillionth of a liter. So they're not very big. And each red cell contains about 250,000 molecules of hemoglobin. And they live for about 120 days. And there's an electron microscope picture of one. And it looks a bit like a donut. They're actually what's called a biconcave disc. If you turned it on its side, it would look that sort of shape. Now, the idea of that is it gives the maximum surface area for picking up oxygen or carbon dioxide and transporting it either way. If it was a sphere, wouldn't be able to pick up as much. And it's flexible because it's got to go through the tiny capillaries and into the lungs as well. As I said, its sole purpose in life is to carry hemoglobin around the body. That's all it does. And that's a hemoglobin molecule. You've got 2 alpha chains and 2 beta chains. And in each of those, there's an iron molecule. And it's the iron that the oxygen binds to when it's picked up in the lungs. It's taken back to the tissue where it gives up iron and picks up carbon dioxide to take back to the lungs to expel. And it's actually got a greater affinity. It's not that it gives up the oxygen. It's just got a greater affinity for carbon dioxide. So it's going, oh, it's some carbon dioxide there. I'll have that rather than this oxygen. And it's just a convenient process to keep us on our toes. So what sort of thing do we look at with the red cells in hematology? So the classic ones are anemia. And I hope you're pleased to see I've spelt it the proper way, the British way, not the American way. This one here is an iron deficiency anemia, which is probably the most common, more common in women than men, particularly premenopausal women for, I'd like to say, obvious reasons. If you get a man with an iron deficiency anemia, you tend to worry a little bit more than if you see a woman with it. The one thing I would say about iron deficiency anemia, a lot of people seem to take iron just sort of routinely. It's a waste of time. Iron is toxic. Your body won't retain it. If you're not iron deficient, you'll just get rid of it. It's very good at retaining the iron you've got in the system. So, and you can see these cells, they're very pale. They haven't got much hemoglobin in them. So that person's going to be anemic. Now, you can either treat it with iron, or sometimes it gets so extreme you have to try to treat it with a transfusion. This one, I haven't just expanded the picture. These are macrocytic cells. They're big cells, which is what you get in B12 and folate deficiency. Again, folate deficiency, more common in women, particularly pregnant women, which is why very often they put on folate supplements. B12, you've got quite big stores of that. And again, I heard recently of someone getting B12 injections as a thing. They hadn't been checked as B12 deficient, but they were getting B12 injections because it made them feel better. I don't know how that works personally, but anyway, someone might explain it to me. It used to be known as pernicious anemia, which is probably where is a more familiar name. And it was called pernicious anemia because they didn't know how to cure it. It was only later on when they found out it was caused by either a B12 or a folate deficiency, they could then cure it. Now, some of the more interesting ones, sickle cell anemia. There's a sickle cell. There's a very good sickle cell. More there. Now, what happens in sickle cell anemia is if the patient is subjected to low levels of oxygen, altitude, or going to theatre, if they don't know they're on it, the hemoglobin forms rods in the red cell, and the cell stretches around them to give you that sort of shape. Now, the problem with it is, there's a couple of problems. Obviously, the body recognizes those are abnormal and takes them out in the spleen and the liver. And they then get anemic from that. It's called a hemolytic anemia. Or they get stuck in the capillaries because they're not flexible because you've got this crystalline rod in them. And that causes extreme pain, I'm told. Now, it's more common in Afro-Caribbean populations. So you tended, if an Afro-Caribbean person was going to theatre, you would often do a sickle screen on them so they knew to keep the oxygen levels up to a higher level with them. And what's interesting with it, it kind of links to that. That's malaria, which I'll come back to in a minute. And people often wonder why that's a genetic change. Why hasn't it been selected out as part of natural selection? Because it's not something you want, but they think it offers some protection against that because the red cells are removed from the system more quickly and therefore don't get a chance to reproduce and develop. There's a few types of malaria. I'm going to say this now, I hope there's no one. Are there any parasitologists in the group? I think it's one called falciparum, which is the one you don't want to get because you got multiple parasites in each cell. When I moved up to England, I got laughed at because down here we used to call it falciparum. And when I said that up there, they said, what? There's no such malaria as that. And apparently the correct pronunciation is falciparum. So there's others, there's called ovale, vivax, and malariae. So there's 4 types, but this is the one you don't want to get. That's an incredibly heavy infestation. So I would say if you're going anywhere with malaria, make sure you take antimalarials. Homeopathic remedies don't work with it. You need to take proper antimalarials. These come in, they often get referred then up to the School of Tropical Medicine up in London, and they'll confirm what type it is. But that's not a very well person, that one. Okay, white cells. You get an infection. Your white cells react immediately. They get sent out into the system to where the infection, so whether you've got to cut that, that's why you get a little white spot. If you've got a spot, it's the white cells there fighting the infection. Those are neutrophils. They're the ones that chomp up the bacteria. Those red cells, actually, I don't know what is wrong with this person, but these red cells are not normal. They're not very well. So you can see that that's a very high neutrophil count there. There's not many other types of white cell there. The other thing we look at with white cells are leukemias. That's an acute lymphoblastic leukemia. There's many types you can get of all the white cells. You can get acute myeloid, acute lymphoblastic, myeloma, all those sort of things. We can see there, if you compare it to those slides earlier of a normal blood, you can see the kind of number of white cells you got there. And the problem you've got is it's a soft tumor. And what happens is the bone marrow sort of stops maturing cells. So all you get are immature white cells coming out, and they can't do their job. So the risk you get is you get a chance of infections. You don't fight viruses off. You don't die of the leukemia. You die of the consequences of it, if you like. But these days, compared to when I started, the survival rates are incredibly improved. It used to be months when I started work. It's now years, even for the most severe leukemias. And that one is one of the ones you get the highest white cells with. All right, let's go on to coagulation. Now this might, what is coagulation? It's the action or process of a liquid, especially blood, change into a solid or semi-solid state. So if you cut yourself, you'll eventually stop bleeding. If it doesn't work well enough, you're going to bleed too much. If it works too well, you're going to get a thrombosis. If you get a thrombosis, you're going to be treated. But you're not going to be treated with blood thinners because there's no such thing as a blood thinner. And I'll explain that in a minute. They do many things, the drugs you get given for clots, but they don't thin your blood. Anyway, I'll be testing you on this later. This is a simplified coagulation pathway. And what you have in coagulation, you have a number of factors which work in a cascade to form a clot. And then you've got, where is it? You've got these here which help restrict that, because what you don't want to happen is that to happen too much. If that happens too much, you can have a thrombosis. If it doesn't happen enough, you'll bleed. And it gets two ways of activating. The contact phase, that's if you cut yourself. You expose collagen in the blood, and it activates this pathway coming down through factor 12 down to here. Tissue factor, that can be stimulated by anything like burns, infection, and that activates this side of it, and they join up here in the common pathway. Now, when I said there's no such thing as blood thinners, some of you, including myself, will be on anticoagulants like apixaban or warfarin in the old days. And what apixaban does, it inhibits that. It doesn't thin your blood. What it does, it just slows that factor down there and slows that process down. So your blood's not getting thinner, it just clots more slowly. Warfarin worked on these, factor 7, 2, 9, and 10. It worked in a different way. So it's an easy thing to say blood thinners, but for us people working in the lab, we used to get quite, oh, there's no such thing as a blood thinner. Why do they tell people? I suppose it's a bit easier than explaining that. Now, up in the middle there, you can see this one, factor 8. And that, oh, I'll show you this. There's another analyzer. Again, another Greek god. And that's what we do the clotting on. When I started, we used to do it manually. You'd see the clot forming in a tube. But again, sheer numbers, you get hundreds a day now. So we have to have these analyzers. So factor 8, Queen Victoria, she was a carrier of haemophilia. Now there's been a bit of a debate lately because there's two types of haemophilia. Haemophilia A, which is factor 8, haemophilia B, which is factor 9. Now some people think she had haemophilia B. It's irrelevant really. But she was a carrier of the haemophilia gene. Now it's one of the few illnesses that us men get worse than women. I think, yeah, it's terrible, isn't it? Women carry it, we suffer from it. It's one of the very few. I'm quite happy to admit that. So Queen Victoria, through her daughter, I got her name here. No, that's the granddaughter. Her daughter was Princess Alice, and she married into the German royal family. This is her daughter, who was also a carrier of haemophilia, who gave it to this lad, who is the Tsarevich Alexei. Now, back then, there was no treatment for haemophilia, and the main problem was, with haemophilia, you bleed into the joints, like your knees and your elbows, and it's incredibly painful, causes arthritis into the joints, and is very debilitating. And obviously, sadly, he died at a young age from bleeding, but not caused by his haemophilia. But this guy got into the royal family because he convinced them he could cure him, as well as other things that I've read about with the wife of the Tsar. But yeah, he claimed he could cure the young lad, and he couldn't do. Alex Dowsett. How many of you know him? Yeah? He's just recently retired. He's a British cyclist, held the world hour record, cycled in several Tour de France's, and he's a haemophiliac. Now, it just shows how the treatment of the disease has progressed. That this guy can come down a mountain in France at 70 miles an hour and not, well, obviously you worry about it, but not because of his haemophilia. And that's because, and I went to talk by his doctor, and what they do, they manage his factor 8 levels by treating him before big events. So he's got a normal level of factor 8, so he can go off and do all that sort of thing. He was an amazing character. I mean, you know, I think it's incredible that we've progressed to that level now compared to not that many years ago where you couldn't treat it. I want to mention this. Now, personally, I think this is worse than the post office scandal Over 30,000 people were infected. Probably more than 3,000 have died. And it was all because we didn't have enough product of factor 8 to treat all the haemophiliacs in the UK. So we bought it in from America. And one batch of factor 8 would normally have around about 40,000 donors in it. And all it needed was one of those donors to be infected with HIV or hepatitis C, and the whole batch was affected. And the scandal was, it was known. It was known it was a risk, and doctors who had written protocols for not treating children with factor 8 bought in from abroad continued to treat their patients with it. It's all come out in the latest report. Also, there was a school, I can't remember the name of the school now, where they essentially experimented on the pupils with different models of factor 8. I can't remember the name of it. I'll look. And they were there, and they weren't told. Their parents weren't told, and they were just all treated with infected blood products. So it wasn't just factor 8. It was hepatitis C as well, which was in blood transfusions. Is that my ring doorbell going off? Thankfully, we now manufacture factor 8. It's not a human product anymore. And there's different types of factor 8 that are given to patients. And the same with blood. Blood is screened now for HIV, Hep C, Hep A and B. But thankfully, various governments of all colours, and I won't be, have kicked this down the road about giving these people compensation. The Scottish government, to be fair to them, paid compensation to the patients in Scotland. But thankfully now, since the final report has come out, they've agreed to pay them, and some of these families are going to get millions of pounds. But it doesn't compensate for the fact that 3,000 odd have died. I know one hospital, and I was told this, and they knew all of their long-term haemophiliacs were HIV positive. It's, from a purely personal point of view, I'm glad I didn't work in a haemophilia centre. So but it's, because the thought of having given this stuff to patients is, but anyway, blood transfusion, a more cheery subject. Again, William Harvey, circulation of blood, red cells. First recorded successful transfusion, transfused a dog with blood from another dog, kept it alive. It was in 1665. They transfused blood from sheep to humans. Now, the fact that the humans survived, I think, was more by luck than judgment. And I don't think it had anything to do with the transfusion, to be honest. I wonder what the process was like in 1667. I suspect the sheep didn't survive. And the first successful transfusion of human blood to a patient was in 1818. Again, lucky the patient survived. They're lucky they got the right blood groups. Because if you transfuse the wrong blood group, it can be fatal fairly quickly. And in America, they decided to transfuse milk from cows, goats, and humans. Well, that was replaced by saline in 1884. They thought that might be a more ready supply of that. And people they were obviously lactose intolerant because they had adverse reaction to the milk. Okay, there we are. There's a sheep kindly donated. He doesn't look very pleased, does he? Oops. That's not a happy sheep. Mind you, he's not a very happy human either. And it was a normal sized sheep, but it shrunk down as they've taken all the blood out. And I'm not really sure. That's obviously a tourniquet of some kind that they tighten up around it to squirt the blood in there. That looks like a pump of some sort. I don't know. It's, here we are. There we are. There's a chap giving his blood kindly. I mean, that doesn't look very safe either, does it? It's pouring out of his arm into a funnel. And the chair on the bed to hold. She's looking away. She's obviously very wise. Thankfully, it's got a bit better since then. So this guy should be a lot more famous than he actually is. Karl Landsteiner. In 1901, he identified A, B, and O groups. And in 1940, the rhesus groups. If it hadn't been for him, a lot more people would have died. To get that was just incredible. And it's called O because you've got A and B and you've got anti-A and anti-B, but you've got O, there's no anti-O. So it was originally called zero. Because people often wondered why it's called A, B, why isn't it A, B, and C? It was originally called zero because there was nothing there. And they thought, well, we can't call it zero, let's make it a letter instead. And that's why it became O. So people should know about him. He's an incredible guy. So there's your blood groups, ones we all know about. Rhesus positive, rhesus negative of each of them. But there are 33 other blood group systems as well. And these are all checked for when you donate a unit of blood. They'll check for lots of these. They have panels, the screens for all these, with over 300 different antigens. And they've got names like Kell, Duffy, and Kidd. So it's something you'll never hear about, but they're critical because they can cause transfusion reactions as well as the A, B, and O groups. So we've got a screen for all of those when we get blood donated and when we're going to give it to someone. Because the important thing in transfusion, what they do in transfusion, is to make sure that the blood that's issued is compatible with the patient it's given to. So there's multiple checks all the way down the line, right until it gets to the bedside. So if any of you ever had a blood transfusion and they come to the bed with a unit of blood and say, oh, here you go, Jeff, here's your blood. Tell them, are you going to check who I am? Are you going to check my date of birth? And all the rest of it. Because it's got to be done all the way and they've got to be signed for all the way as well. It's critical. Okay, compatible blood groups. If you're AB positive, then people know their blood groups here. You're very lucky. You can have all of that blood if you ever have to have a transfusion. You're likely as not never not have your blood. That I'm not sure about. I'm not sure. So working your way down, where it says you can't have negative or positive, in some extreme circumstances, you would give a negative person positive blood. But the next time you transfuse them, you couldn't give them positive blood then because they'd have formed antibodies against it. So right down the bottom with O neg, where strictly speaking, you should only ever have O neg. Now I'm B positive, which is quite interesting because in the UK in general, 9% of the population are B positive. In Wales, 15% of the population are B positive, which is the same figure as in the Mediterranean people. Just an interesting fact I quite like. So there we are. That's what we can get. So that's what we look at when we get your blood in. We check what your blood group is, and then we look at what donor you can get. That's what the blood used to come in into blood banks. Not the safest thing in the world. Not easy to store. And you couldn't do a lot with it. So in 1950, someone came up with this. It's been modified ever since. But you can see it's much easier to store. You've got these valves at the top, which means you can take blood, or you can spin it down. You can take things like the plasma off it to use. You can take the platelets off it to donate, because all of those can be transfused separately. And if they're given as a concentrate, they have much more effect than if you just get a unit of blood. So you can see there all the barcodes, they will all have gone on through the process of being checked in the blood transfusion center, which is down towards Cardiff, I believe. I'm not sure. And they put the blood group on. Now, they used to, when I started, these used to be colored labels. And they realized that some people who were colorblind weren't checking the group. And they were picking the wrong one out of the fridge. And it was only picked up when they did it. So they decided that all the labels would be white with the group on it. And there you can see it's much easier to store those in a blood bank. There'd be another section to that fridge. In my lab, we used to keep sort of 40 O positive, 30 odd O negative, and going down with the less common groups. So they all come in, or the other advantage with the plastic ones, where they came in really into their own, was during the Vietnam War. Because they realized they could, when they had a guy on a stretcher, they could slip the blood bag underneath him and he'd push the blood in. So they didn't have to have it up on a stand. And also, if someone's in theatre and they need blood put in, you can squeeze the blood in rather than out of that bottle, which you couldn't really do much with. Finally, I'd like to introduce you to these guys. They're the guys who used to work in my old lab. They're biomedical scientists. This was taken during COVID. That's why they're all wearing masks. They're not hiding. And as I said, they work 365 days a year, 24 hours a day. The labs are open. 60 to 80% of results of diagnoses are involved with these. So I'd ask you not just to remember these, but other staff groups. Hospitals, it does get frustrating sometimes when it's always about doctors and nurses. Because these guys, the physiotherapists, the pharmacists, the x-ray staff, are all important. And if I can ask you one thing from today, please remember all the other guys in the lab as well, because they are critical to what's going on. And the porters, the admin staff, everyone goes on, there's too many managers. We couldn't run a hospital without the admin staff. The place would fall apart. But there we are. Please remember, that's Heather, that's Jade. But thank you for that. That's where I want to finish. So thank you.
Thank you. Okay, ladies and gentlemen, anybody got any questions they want to ask? Please wait for the mic because we are recording this.
That's where it is. Lots of hands gone up.
Good afternoon. When whole blood is taken at a transfusion centre, how long does it take for that patient to restore his level of blood cells? Red cells.
Days.
Days. Yeah, I have read it takes 6 months, but not that long.
No. Well, if you're producing 2 million red cells a second, it's going to be quick. Yeah, it's not going to be long.
Sorry. Hello. Yes. What do you test? What exactly do you test donated blood for? What sort of illnesses? If I give a pint of blood, what exactly do you test that for?
But what they test it for are things like HIV, hepatitis. Those they screen you out. I think usually they can't screen it for every illness.
So you're not testing for general illnesses?
I mean, sometimes they do. Usually, I think they do a full blood count on it when it goes in. So if you're contacted by them, they may well have picked something up, like you might be anemic, or they might have noticed something, your white cells are up or something like that. But that would only be as an incidental finding from the other testing they do. I've got to be honest, I didn't work in a transfusion centre, but the main ones they check for hepatitis, A, B, and C, HIV, those sort of things. But you get the screen when you do, or you're a bit anemic, go to your doctor, or sometimes they'll do some other tests and they'll advise you to go and get screened. They wouldn't do further investigations on it.
Right. Okay, thank you.
Is that okay?
Thank you. I've got two queries actually. One is, how many people in this room know their blood group?
There you go.
Because,
sorry.
Yeah, I find that not a lot of people know their blood group in the UK. And the thing that worries me most is like rhesus negative mothers, first child, it's important that the child is rhesus negative. And if it isn't, how do they know? Because nobody knows. My sister's rhesus negative, my mother was.
If a mother's rhesus negative, the baby's group will always be checked after delivery. And if that baby's a rhesus negative mother will have been given anti-D during the pregnancy. Anti-D, what anti-D does, it gets into the system and it will mop up any fetal cells that are rhesus positive. And I didn't bring it up, it's been a massive medical advancement in saving babies' lives, because the first baby won't be affected. If you've got a rhesus positive baby on the first pregnancy, they won't be affected generally. Second baby, could be badly affected to the point of it could kill them.
But when do they actually start testing the babies? Because my sister, well, her eldest is what, 48, the youngest is 37, and they were never tested. She never knew their blood groups, and she still doesn't.
We
You know,
I was going to say
they
started
weren't told.
in 1978. Yeah, I started in 1978, and we were testing then.
But they weren't told. The parents weren't told. But the second question is why?
But perhaps if the baby was rhesus negative, they wouldn't have told them.
Yeah,
Because
well,
there's no further.
Yeah.
If the baby's rhesus negative, you don't have to do anything.
Mm.
And it's only the last sort of 20 years that prophylactic anti-D's been given during pregnancy. It used to be they waited until post-pregnancy and anti-D was given then.
And the second question I have is, why do people who have the Epstein-Barr virus can never give blood again? So people who've had glandular fever apparently have the Epstein-Barr virus for life, but we can never give blood, and I've never understood why.
I suppose because you could transfer the virus.
But is it that, I mean...
Yeah, well, if someone's getting transfusion, you basically don't want to give them a virus, do you?
I just wonder what the virus was, because we're never
well, Epstein-Barr, I mean, it causes other diseases apart from glandular fever. It can cause, different complaints. So you don't want to give anyone. If you know someone's got a viral illness, you wouldn't give it to them.
Yeah, just nice to know.
Knowing your blood group, it's great to know your blood group, but just to reassure you, if you don't know it, and you have to go into hospital for a transfusion, everyone's blood group. They don't rely on someone going in and saying, "I'm B pos." We check every sample. I mean, I will admit, when my wife had the baby, she needed blood, and I actually told my friend who was working the wrong blood group for her. So thankfully he checked it because I was in a bit of a state.
Yeah, still on blood groups. The old hunter-gatherer Homo sapiens, when they came out of Africa, was O the main or the only blood group at that time?
No, there's always been a variety of blood groups, but it's always been the most common.
Oh, right. I thought it developed when we had agriculture and people A's and B's were more lactose tolerant.
There's been a lot of things about blood groups having links to diet and this, but there's never been any, as far as I'm aware, any evidence that it's true. I mean, if you've got something that says different, I'm quite happy to read it. Always the most common, but 40% of the population are O neg is AB neg is the least common, I think. I'd say B is about 9%.
Two questions. First one, very quickly. How long do the blood pouches last in the fridge? The ones that you were showing?
Well, they could theoretically last 120 days from donation, but you don't keep them that long.
Right.
You keep them for a couple of months, because as they get older, the functionality of the red cells gets less. So you don't want to. I mean, if it's just for volume, you can give that to someone. If it's a bleed, you would give them maybe the older blood in the blood bank.
Right.
But if it's someone who needed it for an anemia, you give them some. And children get the fresher stuff.
The other question is, you hear about people having a blood test for one thing and then something else being picked up. How wide a range of things can you pick up from a blood test?
I mean, if you looked at that blood result I put on there, you're looking at the white cells, the red cells, and all the values to do with them. So if they think, or you've got very often things like leukemia are incidental findings to someone going in and having a blood test for anemia, or they feel a bit run down. The classic diagnosis we used to have was tired all the time. And very often you'd find something like that. I worked in a lab, and this proves why you should never do your own blood tests. One of the doctors put his own blood through the analyzer because he was feeling a bit out of sorts, and he had acute leukemia. It would indicate it from things like anemia. There are tests, there are tumor markers that can be done, but they have to be specifically asked for. There's tumor markers, which is biochemistry. There's tumor markers for things like breast cancer, prostate cancer, those. PSA is the classic one in men. It's not perfect, but it's better than some of the alternative procedures for having your prostate examined. But But yeah, it can be indicated. But if a doctor suspects something, then there are specific tests that you would go to have a look at.
Just to make a comment rather than a question, there's a group of people in America, and they have a belief in what they call intelligent design. They're anti-evolution. And one of the main reasons, one of the main arguments they make against evolution is the complexity of the natural world. And their favorite example is blood clotting. In their literature, they claim there's 53 separate steps that we carried in the correct order. And the argument is that could not possibly have arisen, that system, through any natural process, through natural selection. It's just too complicated.
Yeah.
They claim it's irreducibly complex. Therefore, there could have been evolution, therefore there's a God. So maybe from blood to God is a short step, I don't know.
Well, it saw me through 41 years in my career anyway.
Hi. I heard about some research that was saying that if you inject the blood of younger people into older people, it has a rejuvenating effect and can add to longevity. Some people are doing that. So is there then an issue if you're taking blood from older people and giving it to younger people that it can impact on their health?
We have no idea the age of the donor when we're giving it to people. And none whatsoever.
Has there been research done to look at the effect of that?
Well, I think if there had been, we wouldn't be where we are with it. Because as I say, the blood that comes into the labs has no indication. We have no indication who the donor is or what age they were or anything like that. So, it could be the youngest of us here or the oldest of us here. I don't know. I'm not sure whether the transfusion service, whether there's an age limit on donating.
If you haven't donated, you stop at 65.
Yeah.
Those that have previously donated can continue as long as they want to.
Yeah. So I've never seen anything that would indicate that. Yeah.
You didn't mention factor 5, but you talked about haemophilia, but not thrombophilia.
Well, thrombophilia, I don't know whether we can go back to this off now. At the bottom of that chart there, actually thrombophilia is something the bleeding disorders we've kind of we've done those. And the last few years of my career, thrombophilia was something that we did a lot more work on.
Thank goodness.
And if there was a thing down the bottom with protein C and APC, those are the things that are deficient. They can be genetically deficient, causing the thrombophilia. Really, the treatment for it is anticoagulants. It's just a way of slowing the clotting process down. So
it's identifying the person. It's a personal question because I'm the mother of a thrombophiliac family.
Are they treating them with anticoagulants?
Well, yeah.
Yeah.
My granddaughters who become pregnant, it was too late for my daughters who lost lots of
I think when they're pregnant, they probably treat them now with low molecular weight heparin, I think.
They are injecting heparin as soon as they're...
And when she's not pregnant, she'd probably be put onto something like apixaban or something like that, I would have thought.
Yeah.
I think they tend not to use warfarin quite so much now because...
Well, I've got 2 children who've been on warfarin, one for 25 and one for 30, and are still...
The new anticoagulants are a lot more convenient. You don't have to be tested. The side effects are less, and it's a lot less fuss with them. And the worry when we started on the new anticoagulants was there was no way of reversing them, although the effect went out your system quicker. There's now some drugs coming on that can reverse the effect of the new one. They're called DOACs. I don't know. There may be some people in here who are on them. I put my hand up for that.
So do you forecast that things will improve for my grandchildren or my great? I've now got great grandchildren.
I mean, just since I've been in, the treatment on these things has progressed dramatically. Just the identification of thrombophilias. I'd never heard of a thrombophilia when I started in the lab. By the time I finished, we were doing tests on 10 a day. Not all positive, but we were testing that many people. The risk of clotting for them. You know, if you get a DVT or whatever, then you're now investigated for that sort of thing.
It's not always taken very seriously. For instance, with my children traveling,
Yeah,
and my grandchildren and my great-grandchildren, they're not always prescribed anticoagulants for when they're traveling, and
yeah,
they ought really to
you
inject
should do. Yeah,
if they're traveling for more than 2 hours
yeah.
at a time. But
It,
it's not
it is
taken
it is taken a
seriously.
lot more seriously now than it was.
Thank you very
I
much.
mentioned haemophilia and clotting because I go into the royal family then. It's one way to have a little go at the royal family.
One more question.
What?
We can't hear the question, so can we pick up a question with a microphone here, please?
Okay.
Hi, I would just like to say about my daughter-in-law who lives in New Zealand, and she's got a rare blood disease, blood group, but they wouldn't take her blood because of mad cow disease.
Because she was from the UK. Yeah. Yeah. It's because she's from the UK. Yeah. I mean, it's interesting. I heard of someone the other day who'd been diagnosed with CJD. So it's still about. Still about.
Yeah, I know that's very common in Australia and New Zealand because my son wasn't allowed for a long time to give blood in Australia, but he can now. So there you go. It's because their tests have changed and what they do. Thank you, Andrew. Amazing talk. Really interesting. Lovely questions, everybody. Thank you very much indeed. Do appreciate
Thank you.
it.